So we'll now move to our next lecture. It's from Professor Hugues Duffau. The neurosurgical community don't need an introduction for Professor Duffau. He's become one of the neurosurgeons of our generation, defining our generation, a scientific surgeon who has dedicated his skills and scientific mind to further the brain tumor, particularly low-grade glioma tumor management, and in doing so, um, spawned other areas that will lead us for further understanding and advancement in neurosurgery. So, Professor Hugues Duffau, thank you very much, sir, for your time, and I look forward to your lecture. Thank you, sir.
Thank you very much for your invitation, and congratulations, Naren, for your fantastic meeting. I'm happy again to have this opportunity to show new slides and new results and a longer follow-up regarding now this 28-year experience with more than 1,300 surgeries performed for low-grade glioma patients. And based finally on the fact that I started to develop the concept of connectomic neurosurgery and connectomic neuro-oncology more than 20 years ago. And I tried to summarize this view recently in a paper I published in the Lancet Neurology, trying to explain that for young neurosurgeons, you have not to imagine when you are in front of low-grade glioma and diffuse glioma in general, that you have a tumor mass pushing the brain around. But in fact, it's a much more diffuse disease and inducing modification within the full brain, including both hemispheres. So that means that you have to try to better understand what happened before the diagnosis in order to better understand what you will develop, and especially the concept of supratotalization. I mean, not only to take care and take into consideration the core of the tumor, but the periphery of the tumor, the so-called peritumoral zone. Because in fine, as you will see with long-term follow-up, then the diagnosis and most of all the prognosis depends on what we cannot see on the preoperative imaging, whatever the advances in this field. And to better understand what happened before the diagnosis, I developed the concept of backward modeling paper just this week by trying to explain that when we see a patient with first symptoms, like epilepsy in the vast majority of cases, then we have to understand that the brain adapted for many months to many years and sometimes many decades before this first symptom, which is a kind of alarm warning because a first degree of limitation of neuroplasticity. So that means that you can have a recruitment of the perilesional zone, but also more for located recruitment areas within the same hemisphere and sometimes within the contralateral hemisphere. Then the pattern of reorganization, when you see a patient with the same tumor in the same location, with the same volume, and eventually the same molecular biology, the pattern of reorganization of the brain is not similar. So that means that the surgery should be totally different, adapted to the interactions between the brain and the connectome. And definitely we have to better understand that before to go to the operating theater. Typically, because I will publish the most extensive series about insular low-grade glioma in a few weeks in Journal Neurosurgery, more than 300 cases. Then I observed that before to go to the operating theater, you had an increase of the morphometry, the volume of the contralateral insula within the contralateral hemisphere. I insist about that in adults. So with an increase of the volume, but also an increase of the functional connectivity. explaining why the brain was able to compensate. And finally, you have a patient in front of you who is, in the vast majority of cases, in the Grade Glioma, able to enjoy an active life. And of course, we can use reorganization in order to do sensitization, not trying, I reinsist about that, to remove tumor mass which does not exist, but trying to remove a brain invaded by a chronic tumoral disease as much as you can according to functional boundaries. So to do it, and you will see the new results now, you have to be a neuroscientist. I know I have the habit to say that for 25 years, but finally, to be honest to the young generation, I'm a little bit disappointed by the previous generation because so few neurosurgeons made the effort to really understand the brain. They use tools like DTI, fMRI, and so on, and they have a feeling to be neuroscientists. Forget it. There's do nothing. What we have to understand is the reorganization within and between networks and to participate in the elaboration of new models of cognitive neuroscience because we should be neuroscientists because we are into the contact of the brain of the human beings for 30 years. So definitely localizationism does not exist. Then we went toward the level of networking brain, then toward the level of meta-networking brain, network of networks. And now we will demonstrate that there was a constant modification within these interactions, not only between networks, but also between the brain networks and the tumoral network, changing also over months to years. So everything is dynamic. So by understanding this concept of dynamic connectome-based surgery, and not just speaking about 3 beautiful images on DTI, which is not a connectome, then we were able, after 28 years, for the first time in the literature, to increase the level of survival beyond 20 years with a prospective collection of data, but also by preserving the quality of life in 99% of patients, including 95% of them able to return to work. And so for a long time, I mean at least 15 years of an active life. And definitely, this is the first time in the literature, and I hope it will not be the last time. But everything is depending not only on the understanding of tumor, but on the understanding of the brain. Otherwise, you will not succeed. So I will not insist on the fact that the Grade Glioma, of course, involved in the vast majority of cases, young people between 20 and 50. They are not benign. They will become malignant if left untreated. And when we do a systematic objective pre and post-operative cognitive assessment, in more than 50% cases, finally, they are not so well. They have at least 1 to 2 domains of cognition with some degrees of fragility related to the fact that the brain reached the first level of limitation of neuroplasticity in epilepsy, as I said. Okay. What we have to understand, and I will continue to insist about that, not only for neurosurgeons, but also radiotherapists. The limitation of neuroplasticity is mainly represented by the connectivity, so the white matter tracts in the brain. If you have an invasion of the inferior frontooccipital fasciculus before any treatment, at the time of diagnosis, very frequently the patient will have some degrees of mild but objective semantic disorders if you do, of course, an extensive cognitive assessment, which should be done systematically. Otherwise, you will say, oh, the patient is well. No. So we have to understand the individual functional anatomy of this patient at a time. And definitely, if you have 2 patients with the same tumor, the same volume, the same location, the same molecular pattern, you cannot do 2 similar surgeries. Otherwise, you will fail. and never you will reproduce my results, which is not a goal, explaining why I'm here today. I would like to be helpful for more patients than only my patients. To achieve these results, you have definitely to understand that functional imaging is not done for neurosurgeons. It's done for neuroscientists. So if you would like to become a scientist, to do a PhD in this field, of course, it will be beautiful to use fMRI as a didactic and research tool outside the operating theater before and after surgery to better understand how the brain reorganizes and so on. But into the OR, it does not work. Why? Because if you have an activation, it does not mean that you cannot remove it. Maybe you will see a deficit and the patient will recover. I spent 25 years of my life to operate patients not selected for surgery elsewhere because of fMRI. And of course, these patients are not incorporated in the beautiful series based on functional imaging. It's a bias of selection. It's a nightmare to consider so many patients not selected because of fMRI. It happened to me this week. Not selected for surgery because the grade glioma within so-called Broca's area. Everyone will say, oh, you are telling systematically the same thing, Duffau. But because you have not understood. And then the patient was biopsied elsewhere and finally came to my hospital. And what I did is more than 98% of resection within Broca's area, and the patient is well. DTI does not work. DTI is just biomathematics. DTI is not a function. It's not my imaging. This is the truth. I am involved in the real DTI challenge. I mean, with experts in this field, not neurosurgeons, but the real neuroscientists in this group dedicated to try to improve the reliability of DTI, because experts in this field in the world will tell you that DTI cannot be used into the operating theater because this is not reproducible. For instance, here you can see just to have a reconstruction of the pyramidal pathway in green, which is simple. In fact, with the same subset, you had 4 different reconstructions by 4 different experts in the world today. So how do you want to use it? So that means that, of course, since almost now 30 years, I understood that I have to talk to the brain directly because I am a brain surgeon, and then I will spend my life within the central nervous system of human beings. It's exactly what I did by asking the patient to be awake into the OR and then to benefit from cognitive assessment in real time during cognitive monitoring plus intraoperative electrical mapping, both at the level of the surface and the white matter tract. And of course, the tasks are adapted to the needs of the patient, not only to avoid hemiplegia and aphasia. You know, in meetings of neurosurgery, I will go to Boston for the AANS meeting. I'm sure that I will participate in a beautiful session, but with that after surgery, and then the patient is happy according to his neurosurgeon. No. The question is, what is the feedback of the human being in front of you 5, 10, 15, 20, 25 years after your surgery? And then you have the solution. And I have the answer because I continue to follow my patients, coming, as you can see, from more than 30 countries, speaking different languages, and deemed inoperable because the weight of the localization is, oh, this is in Broca's area, I cannot operate. That's crazy. So please understand what means connectome and not just 3 beautiful images with 3 different colors showing the great fasciculus and the pyramidal pathways. I can use this kind of imaging too, but it will never reproduce my results. Indeed, I would like to insist on the fact, because this is objective, that these best oncological functional results ever published with more than 20 years of median survival and long-term preservation of quality of life have been obtained without technology, with no money, with no marketing, with no politics. just the understanding of the brain of human being, because it's our job. We are brain surgeons. So no neural navigation, no DTI, no fMRI, no intraoperative MRI, no microscope, no robot, and so on and so on. But that means that you do not need money. You can do it everywhere in the world. So now, that means that you have to reproduce this kind of results everywhere in the world. You do not need the beautiful software of BrainLab in order to have these results. It's the reverse. If you use technology, please show me any papers showing more than 20 years of median survival in the Grade Gliomas surgery. Now, it's just for fun. Why? Because are developed by people who do not understand the brain and continue to speak about localizationism and continue to speak about dominant, non-dominant hemisphere. What means non-dominant hemisphere? I claimed for 20 years that I need both hemispheres in order to have my brain, my behavior, my results. It's just an evidence, of course. So you need right non-dominant hemisphere for high level of cognition, of social integration, of executive function, of why not also emotion. Also for sleeping, you need your right hemisphere to sleep. So what we did is to ask to the patient into the operating theater to do many tasks simultaneously as in the real life, to move, to speak, to understand, to self-evaluate with a time constraint. I mean, more than 5 seconds, it's not good, because in real life, you have to make decisions in a few seconds. Otherwise, you cannot have adapted behavior. So what I do is, of course, to stimulate cortically in a patient doing movement, language, as I said, but also other tasks adapted to the wishes of the patient, according to her job, according to her needs, lifestyle, and language. And very frequently, my patients can switch from one language to another one. And of course, they will continue to do the task throughout the authorization for 1 to 2 hours. And in the end, when you will stimulate the connectivity, so not one, but disrupting the network, suddenly the patient will have disturbances. So that means that you have to stop, even if there is an invasion at the level of the connectivity. Otherwise, your patient will return to normal life. And what they want is to continue to live. Reaction time can, into the operating theater, give you the opportunity to infer if the patient will return to work. Yes. So that means that if you started to see the patient is able to move, to speak, but not to do both simultaneously and or need more than 5 seconds, be careful, because you know that she will not be able to make decision online in the real life, and in vast majority of cases, not able to resume their employment. So definitely, please, so spend time outside your operating theater, not to reproduce the same thing. Otherwise, after 10 to 15 years, you will be obsolete. And propose new model of cognition, not only to be published in Nature or Science, but to use this knowledge to better operate the patient and to improve your clinical results. And what we discovered really these past 15 years, speaking about only the neuroscience. First of all, that there are some networks involved in the control of movement. So you can ask the patient to move during surgery and to make complex movement or not, according to the wishes of the patient. For instance, it's totally different to avoid hemiplegia and or to be a pianist. So you can induce voluntarily a supplementary motor area syndrome or not. You will tell me, but everyone knows that you will recover after SMA syndrome. Of course, I know that. I wrote that 20 years ago. But it's not true. If you have, for instance, a very high-level sportman or pianist or surgeon, so maybe it could be more reasonable to leave a small amount of tumor to avoid a complete SMA syndrome, to recover completely, to enjoy a perfect normal life. But before you left the tumor, yes, but I will come back. The dynamics within and between networks. So I will be there 5 years later. In the meantime, the patient will not have malignant transformation of the low-grade glioma because of decrease of the volume. And in the meantime, she will enjoy a normal life. By enjoying normal life, you will push plasticity. 5 years later, more. And then you can apply this concept for 25 years. It's exactly what I did. So your patient will live more than 20 years. But to enjoy life, they need also to have the somatosensory feedback. So you need to understand what means not only movement, but also coordination, namely volition of complex bimanual action. This is totally different. And nonetheless, into the operating theater, you can monitor, but you can also elaborate new model of cognition. It's not incompatible. This is the reason why I try to push my plasticity every year by pushing the interactions between my networks as my patients had a modification of the interaction between networks pushed by the tumor. So everyone think that we have understood the described pathway in the human brain this past century. It's totally wrong. We published 2 to 3 years ago in Brain the new way of seeing functional anatomy of the brain. This is the real connectomic and not the DTI. This is the understanding of the cortical termination, but also the different subpathway, and not only based on the structure, but based on the function. Ask to the DTI to give you function. Acoustic encoding, visual encoding, lexical encoding. They know nothing about function when they speak about DTI. So if you know nothing about the function, you cannot promise to the patient that he will recover after surgery. You will tell me, but so many papers show that using fMRI, DTI, and so on, they have good results after surgery. No, they have good transitory functional results. I would like to see the median survival because remember, the goal is to give the opportunity for our patients to live longer and not just to do a beautiful surgery for fun. The inferior frontooccipital fasciculus, not one pathway involved in semantic, but different pathway with bilateral organization involved in verbal, non-verbal, multimodal semantics, allowing us to understand the world. Inferior longitudinal fasciculus. We can do a lobectomy at the level of the anterior temporal lobe. Duffau, I did that many times in my life. The patient is not aphasic and so on. No, but it has an increase of reaction time if you cut too much of the inferior longitudinal fasciculus and you increased the reaction process. We do not care before. Now, but the patient is not going to work anymore. I care for him, her, because they are young between 20 and 50, and they would like, in vast majority of cases, to enjoy a perfect normal life. You think we don't know anatomy? We published in Brain past year a new pathway involving lexical access. Of course, this pathway does not exist in the beautiful Brain Lab software or what you want, Medtronics, I do not care. Because they do not know that it exists. How do you want to operate the brain with high level of reliability without the good pathways? We do not know the anatomy. Show me papers insisting about the executive functions, like working memory, like mental flexibility, and so on, before and after surgery, performed in a systematic manner. And we will continue to do the patient as well, but this is totally fake. It's just a psychotherapy of your surgeon. And you have to understand that SLFE two bilaterally, namely the superior longitudinal fasciculus, are involved, but also involved in spatial cognition and awareness. So it could be critical in the so-called right non-dominant hemisphere if you would like to avoid any neglect. Why to avoid any neglect? To give the opportunity for the patient to drive again after surgery. Because in the vast majority of my patients, everywhere in the world, on 5 continents, if you cannot drive very frequently, you cannot work. We're happy the patient is not hemiplegic. But it was not enough because we needed 15 more years to understand that even if we preserved the SLF 2 and 3, we could induce some attentional disorders by cutting the SLF1 and or the cingulate, depending on each patient and the reorganization of his functional connectome before surgery. Remember the backward modeling. Each patient is unique. You will tell me, are you sure that attentional processing are critical when you have a low-grade glioma? I have not to judge. I have to explain to my patients, and the human being in front of me will decide before to go to the operating theater, and I will adapt my surgical strategy according to his wishes à la carte. For emotional processing too. We can change the behavior of patients by operating on, especially the right non-dominant hemisphere. You sure it's not an issue if the patient is more irritable, with more hypoactivity, disinterest, and so on? And you think that you can avoid that before? Of course, we can avoid that by introducing new tasks, especially to recognize the emotion expressed by faces in front of you, and to switch from language movement to mentalizing. And of course, we have modeled as neuroscientists the different level of so-called mentalizing, namely to recognize emotion, but also to infer the intention of people in front of you. I just research. No, this is the social life. Otherwise, you cannot have a return to social professional activity. We do not care the patient is hemiplegic. I'm happy with that. Okay, if you're happy with that, we can continue to increase the level. The patient to self-evaluate into the operating theater. This is sadness. In fact, it was happiness. But the patient said, I'm sure about that. And finally, it's anosognosia induced by stimulation in the arm. Of course, the patient is not hemiplegic, aphasic, and so on, but with this kind of deficit, mentalizing deficit, and or anosognosia, you cannot return to normal life. But therefore, if you do so many tasks, surgery will be so long. No, because the patient is doing everything in 5 seconds. So my surgeries are very short, and I cannot lie because I received more or less 1,000 neurosurgeons coming from more than 50 countries. I never did a surgery without any observer since more than 20 years, even more or less during the COVID. So they know that the right so-called non-dominant hemisphere is critical for human beings. But you have to model that as a scientist, and you have to demonstrate that it's helpful for patients with gliomas. It's exactly what I did by comparing my first series when I did surgery under general anesthesia in the right so-called non-dominant hemisphere when I was younger, 20 years ago, and the past 20 years, especially for insular tumor. And you can see by yourself, the extent of resection is similar, but I did not induce any severe permanent deficit these past 20 years, and I increased the rate of return to work. But it's only in Montpellier, Dufault. We recently had an analysis and systematic review regarding the surgery under general versus awake mapping patient in the right so-called non-dominant hemisphere, both for low-grade and high-grade glioma. And you know what? Everywhere in the world, if the patients are awake, the results are better. So my question is, why do you not perform systematically awake surgery because this is the state of the art with the best results. Otherwise, show me your results and show me that your patients are living longer and better than mine. Otherwise, I'm sorry, but you have to change your mind and to say that technology is not the solution. It's just the tree hiding the forest, except if you are not interested by your results. Okay, so the results. When I started, the median survival in literature was 6 years, and the quality of life was not evaluated in so-called low-grade glioma. Now, about 1,000 patients, more, but with tumor located within so-called eloquent areas, the Broca's area, the Wernicke's area, the Rolandic system, the corpus callosum, blah, blah. The rate of severe permanent deficit is less than 1%. 99% of good results. I cannot lie. It's a prospective collection of data. The vast majority of my people, of my patients, are coming from elsewhere, including abroad. The mortality is 0. But we also preserved the cognition because we are doing systematically pre- and post-operative cognitive assessment in order to give the opportunity for patients to return to work 94%, in fact, now 95%, which is unique in the world, even by using DTI and so on, plus 80% of positive impact on epilepsy. In order to publish this recent paper in the Lancet Europe, I selected 600 patients, prospective collection of data, but only with the proof that the tumor was IDH mutated, just because we had to apply the new classification in order to be published in Lancet. Okay, why not, if they want. Median survival not reached after 20 years. That means that my patients are still alive, and maybe I will continue to increase this median survival beyond 25 years. I don't know. But what I know is that to achieve these results, only less than 10% of my patients benefited from early adjuvant treatment. Only less than 2% radiotherapy against protocols. Of course, because I will demonstrate to you that if you do radiotherapy at the level of the connectivity, which is the limitation of neuroplasticity in patients who should live 20 years, in the end, they will be with a dementia. So that's crazy. We are not here in order to induce a decline of the cognitive functions of our patients. All series are based on 5 years. But how do you want to infer what will happen in more than 20 years if you stop the randomized trial after 5 years? So I'm continuing this real-life prospective collection of data in more than 1,000 low-grade glioma patients. And of course, if you have statistics and oligodendroglioma, the results are better than astrocytoma. But in all cases, if you do a more complete resection, especially supratotal resection, remember my first slide, we have not to remove the tumor mass visible on MRI, but to remove the brain as much as you can according to the understanding of the functional connectome at the individual level. Functional connectome, not beautiful TTI, colors, imagine. Then suddenly you will preserve the cognition. And we published for the first time past year in Brain 400 patients with cognitive assessment performed after total versus supratotal resection. No significant difference, because I stopped, of course, according to the meta-network I spoke about initially. So the neuroscience applied into the OR allow you to improve the results, including, of course, to also improve the control of seizures in approximately 90% cases in my experience. And what is very exciting is that for the first time in the literature, we demonstrated also that not only the patients are well after surgery, like if you use DTI fMRI without showing the extent of resection, but they continue to enjoy an active life for 15 years, which is unique. Show me these results by using technology, please. Then you will convince me, because technology, fMRI, DTI, we have more than 15 years of that. So they should show these results. Otherwise, no, I will never use something which is not available everywhere. And finally, without any demonstration of the real impact on survival and quality of life. So how to continue to improve the oncofunctional balance? Finally, by arriving, we propose to operate patients with incidental discovery of low-grade glioma. Of course, in these cases, 97% patients resumed their employment with more than 93% of them still alive after 10 years, not only in Montpellier, but also in San Francisco, in Calgary, in Italy, and so on. But because this is a diffuse glioma, explaining why definitely do not rely on MRI, speaking about also oncological issues, because the flare hyper signal is not the disease, you will finally see a recurrence of the tumor even after 5, 10, 15, 20, 25 years. But at that time, the brain reorganized, not only based on the reorganization when you did the diagnosis initially, first seizures, but also induced by surgery, reorganization, also induced by postoperative rehabilitation, which should be systematic, especially regarding the cognitive functions, and the return to work, because to work also push your brain to continue to have reconfiguration. So 1 year and a half ago, we published for the first time in the literature in brain also the modification between the first and second surgery and the different patterns, knowing that the area the most plastic in the brain is the so-called Broca's area. But nonetheless, this week I continue to operate patients not selected for surgery elsewhere because Broca's area is the area of speech. And if you removed it, then patient should be aphasic. It's exactly what was said to this patient. That's crazy. In 2005, 25. So no way to speak about technology. The knowledge is better than DTI, fMRI, and neuronavigation and robot and artificial intelligence. You can remove Wernicke's area, but sometimes you need 2 surgeries with a few years in between. You can remove both frontal lobes in patients with normal cognition, metacognition, enjoying normal life, working, driving, with taking care also of children. But you need sometimes 10 years in between. You are not hurry. In the meantime, the patient is enjoying normal life. We demonstrated that if you could reoperate 3 times by including both grade 2 and 3 high-grade glioma, then the median survival is 18 years. This is unique in the literature too. So, of course, not so good than only low-grade glioma, because I reinsist, incorporating grade 3, but also with long-term preservation of quality of life. Indeed, systematically, my patients are tested not only before and after the first surgery, but the second, the third, the fourth, the fifth. So to help younger people in order to avoid to waste time, we developed so many atlases of real function, not DTI. DTI is not a function. They don't know what means the color. We know because we stimulated all these patients. And what we know is that neurosurgeon is not aware about what means the connectome. Typically, you are a very good surgeon. You are into the operating theater under microscope, removing the insula, and you feel that the tumor is still a little bit in the depth, and you would like to cut 3 more millimeters, just 3 more millimeters, no stroke. The patient is under general anesthesia, of course. No need, like in Montpellier, to have a awake patient. And great surgeon, yes, still. And in fact, you are cutting, disconnecting 1/3 of the hemisphere. And your patient will not return to normal life, will not work, will have tiredness, slowness of executive functions. But you do not care because your patient is not hemiplegic, so you are very good neurosurgeon. You think that this is really the state of the art? Therapy. Recently, I gave this talk Americans told me never we will reproduce your results, Hugues. Why? Because we have to apply the protocol in US and we have to irradiate our patients. But irradiation too earlier performed is dangerous because we will irradiate the connectivity and to induce a disconnectionism syndrome. And for what? To increase the progression-free survival. But we do not care. I was in a meeting of Oncology 2 days ago, and I said, but the PFS is nothing for the patient. What they want is to live longer and better. Yes, but the PFS can give you some information about the survival. This is totally wrong. You can increase the PFS and finally all patients will die. Exactly as demonstrated in this paper, seminal paper published 20 years ago in Lancet. So, and first of all, ask to your patient to benefit from cognitive assessment, not only before and after surgery, but before and after radiotherapy. And what happened within the 5 years following radiotherapy, 50% of patients had cognitive and or emotional disturbances, which is a nightmare. You imagine 20 years later? So please do not follow the protocols. They change every 5 years. And since the beginning, we proposed this connectome-based surgery, but in fact relying on the dynamics of the network by telling, remove as much as you can according to the functional connectome of this patient at that time. Then we will come back, no radiotherapy in the meantime. Then 5 to 10 years later, you will remove more. Then if you can do another surgery, it's perfect. If nonetheless the tumor is migrating to of the white matter tract, give chemotherapy first, because chemotherapy does not induce decline of cognitive functions. Conversely to radiotherapy, show me long-term follow-up with radiotherapy. We should have so many papers. Patients started to be irradiated 20 years ago. So where are the results? I want to see facts. And they were never published. You know why? Because the patients are not well. Here, I started to operate, as I said, for the 5th time. I was not able to publish that before, of course, because I need, like my patients, to be older. More than 20 years of follow-up, no chemotherapy, no radiotherapy. And finally, we started to give chemotherapy between the 4th and the 5th surgery. Patients still able to continue to enjoy normal life. More the tumor will evolve, more you have a risk to see some foci of malignant transformation. If you can tend toward the supratatorialization, even if you have some foci of grade 3 or so-called 4. I do not speak about mild-type glioblastoma, of course, but some foci within in the middle of a so-called grade glioma, because my patients have seen 4 to 5 different WHO classifications. So how do you want to change every 5 years your strategy? You have to anticipate. And you can see that by avoiding chemo and or radiotherapy, despite in the middle of the tumor, I reinsist, malignant transformation, the 5-year survival is 95%. Typically, this patient in 2002 to say no chemoradiotherapy was crazy. Of course, this patient is still alive with 23 years now of follow-up and enjoying normal life. And finally, we are starting only now, after 20 years, to give adjuvant treatment. This is especially true for big tumor. We published the sole paper in the literature 1 year ago with grade 2 and then grade 3 glioma with more than 100 cc. Why grade 3? Because you know that the risk of malignant transformation is directly related to the volume of the tumor. So if you see a giant so-called low-grade glioma, you almost be sure in 90% cases that you will identify some inflammation in the middle. You can see the survival curve, no difference between grade 2 and 3. But that means also that because I trained many young surgeons, becoming now finally seniors and professor, chairman, and so on, many of them were able to reproduce the same results. They are just younger, so that they have not this follow-up. But they applied this concept also to high-grade glioma, question very frequently raised. And you can see that in Italy, for instance, it was clearly demonstrated by others that if you do a supratentorialization beyond the enhancing areas in high-grade glioma, you improve both neurocognition and quality of life, but not relying on DTI, of course, which is not a function. Because we have to be now more objective with the real quality of life of patients living one generation and more regarding typically the return to work. We did a systematic review just 2 years ago, and you can see less than 20 studies tried to better understand if patients were able to return to work. And we are speaking about the quality of life of patients, but we do not care. Sexual disorders. You do not think that it's important between 20 and 50? Only 3 studies about that, 2 from Montpellier. You really think that we are interested by the quality of life of our patients? The creativity. I published recently this paper, and I will publish another one in Journal of Neurosurgery in order to try to open the mind of neurosurgeons by telling if we are human beings living more than 20 years, maybe many of them would like to be creative, the essence of life. We do not care. It's not hemiplegic. Okay, perfect. So, to conclude, definitely you have to be a neuroscientist in order to integrate, but in your own brain, the different pathways, their dynamics, in order to better understand that everything is changing. And when you finish the resection, the state of the brain is not the same than the resection 1 to 2 hours before. So without long-term follow-up, you cannot conclude. It's just surrogate, it's just marketing. So be careful about evidence-based medicine if you have not at least 10 to 20 years of follow-up, including regarding the new drugs in low-grade glioma. And first of all, ask them if they enjoy their normal life according to their subjective criteria after 10 to 20 years of follow-up. And according to that, you can do a real personalized management by adapting your strategy to the modification of the functional connectome of each patient over years, over decades. And of course, if you decided not to give too early chemoradiotherapy, you will be so happy 10 years, 20 years later to continue to say to the patient, now you have a recurrence, so you're still alive, you're still well 20 years later, but I will propose you to do radiotherapy because it's still possible in good conditions because never you have been irradiated. So in other words, in your mental imagery, you have to see these pathways we published. And of course, I continue to love DTI, but outside the operating theater, because we published in Brain past year, the mix between the stimulation into the operating theater and the functional imaging. So with the human connectome, but not into the or at the individual level because it does not work. And would be to continue to induce further level neuroplasticity even after a first surgery or a second surgery, the concept of reorganization of the dynamics of the pattern of reorganization. In other words, the metaplasticity. I will not insist about that, but just to tell you that we have so many solutions, speaking about the connectivity, the plasticity, the metaplasticity, the brain instability. And you know what? In the recommendation today, classical recommendation in US, in Europe, everywhere in the world regarding the management of low-grade glioma patients, nothing is mentioned about the brain itself. That's crazy. You won't manage brain tumor without understanding the brain. So I hope you have understood what means really connectomic neuro-oncology and not just to show two beautiful images with three colors. So the conclusion is that now you have the choice, or to continue to apply protocol under the guidance of artificial intelligence and to say, I am not responsible if there is any problem, versus to treat a human being and to continue to follow him as a medical doctor, a family doctor, a GP, as I did since almost 30 years. If I was able to do it, you should reproduce my results, but also to go beyond. So good luck for that. And of course, I am available if you had any questions. Thank you.
Thank you very much. Thank you very much, Professor Duffau. That was a fantastic talk. I think for me that you combine surgical skills with anatomy, with functional and neurosurgery, with science. It's it's like a four-dimensional neurosurgery. And Professor Duffau, there's a few questions for you, and I think my question would be, I have had the privilege of visiting you operate, Professor Duffau, and that was I certainly was left with immense impression of how you tackle these problems. I think one of the problems that many centers will have is that you have got a nice surgical setup, you have a fantastic neuropsychology setup. And I think in smaller centers or even medium-sized centers, to get the kind of neuropsychological proficiency and to have the number of cases can be difficult, I would imagine. What's your thoughts on the importance of having a neuropsychology, a world-class neuropsychology backup for your strategy of operation? Thanks.
First of all, to have a neuropsychologist is less expensive than to buy intraoperative MRI or something like this. Mm-hmm. Second, it's not dedicated only for awake surgery. I do not understand how it's possible today to have a department of neurosurgery, whatever the country, without a neuropsychologist for a full department. I mean, to rehabilitate or to refer at least to rehabilitation patient after mild injury or after vascular surgery, and so on and so on. That means that definitely we don't know what we are doing. We are not objective, not only for the Grade Gliomas surgery, but in general for neurosurgeons. So we cannot speak about quality of life of our patients. We have to be honest with ourselves and themselves. So if you want to be honest, you have to fight whatever the department in the world to benefit from at least one neuropsychologist and or speech therapist. And then you can build by starting at least for the full department and telling, now we would like to have some hyper specialization. Why not for wake mapping?
Thank you. Thank you, Prof. The question from Dr. George Dimitri is that, which I also was going to probably ask you, is that, you have been ahead of your time, in the sense that, you said the things that now have become standard in low-grade glioma management. And where do you think this is going the next stage? And where do you think, in terms of a general question, as you have always been ahead of the time, where do you think the brain tumor surgery is heading in the next 10 years, 5, 10, 20 years? Thanks.
Of course, they told me that in the Salpêtrière Hospital 30 years ago. Why are you interested by surgery of glioma? In 10 years, we will have the beautiful molecule curing them. And finally, today, everyone is telling, even in meetings of oncology, because definitely I'm regularly invited by oncologists in the world, first of all, you have to remove the tumor as much as you can, whatever the molecular profile. So definitely don't worry for your surgeons involved in oncology. You will be the one if you can deal with the quality of life of your patient by increasing the survival. But never they will cure diffuse glioma by using pills.
Thanks. And in terms of the you mentioned that about being neurosurgeon, neuroscientist, neuroanatomist. You know, do you, I mean, like Pittsburgh having a, a course or training for the radio surgery, would you consider, or do you have a course, week-long course or any sort of program for surgeons for brain tumor surgery or low-grade glioma surgery, or would you consider? Thanks.
Maybe, as you know, I founded the European low-grade glioma meeting 20 years ago. And probably we will reorganize after 20 years next year in Montpellier for the anniversary. And the goal of this meeting is to have not only neurosurgeons, but also neuroanatomists, neuroscientists, molecular biologists, and so on, and everyone showing the results, so facts, based on better understanding of the interactions between the tumor and the central nervous system. So it's not new. And they reproduced exactly the same thing in Asia, the Asian low-grade glioma network based on multimodality. Strangely, it does not exist in US. So I'm asking the question reversely, why? Second, I participate in a lot of dissection training course, for instance, in Spain, in Italy, and so on. So dealing with a neuroscientist. And it's very rare to have neurosurgeons involved in this kind of course, because when they see neuroscience, they are doing seizures. Why? Neurosurgeons should be open-minded by telling, finally, I'm not interested by brain surgery, and I will spend my life by doing, I don't know, skull-base surgery, vascular surgery, spine surgery, okay? But you cannot operate the brain with a high level of reliability, except in emergency, okay? Or to say since the beginning for younger people, then I would like to spend my life in the central nervous system of human beings, and not only dealing with the grade glioma, but with every kind of brain tumors, but also cavernoma, but also AVM, but also DBS, but also why not participate in BCI in order to restore the function of the brain? How do you want that it will be possible for you to do it if you have not understood the brain processing? So since the beginning, you should be hybrid by doing a PhD in cognitive neuroscience, or what you want, TTI, fMRI, regarding the training, then it's very good. You will build your own mental imagery, but by starting to develop something more, and not just to say, are you sure that neuro-oncology will not disappear in your surgery? Of course not, but you will have to reinvent what you will bring, as I did these past 20 years.
Thank you. One question from one of the participants is, what's your thoughts on transcranial magnetic stimulation in localizing for tumor surgery? Thanks.
We started to do it in Montpellier for approximately 1 year, but not to localize the area, to detect the area critical for movement or language. Because first of all, for language, it does not work so much. Second, because for movement, I know where it is. Third, because in all cases, we have the solution just in 15 minutes into the operating theater, including regarding the higher cognitive functions. But the longitudinality of TMS, especially in order to start to predict when to reoperate patients, we already operated on. And you have seen that it was more and more because we cannot cure this kind of chronic disease, but we can give the opportunity for patients to live longer and better thanks to further reoperation, subsequent reoperation. But the question is when and how to select the good indications of second, third, fourth surgery, which is, of course, very difficult because no one knows, because it was not done in the past. I do not speak about enhancement and to try to save life. And at that time, we started to use RTMS in order to know if it could be a predictive factor of neuroplastic phenomenon which occurred since the previous surgery. So which is totally a different question. And the answer is, it seems to work. But for that, we will publish the paper, don't worry, this year.
Thank you. The last question is, in terms of DTI and functional MRI, do you think in the last 20 years the technology is improving to be more reliable, or do you see that there's a fundamental problem with that in terms of localizing intraoperatively? Thanks.
I do not think or believe by myself because I am not a specialist. So what I am doing is to be involved in the international tractography program and so on with a specialist, as I told you. I will be invited in 6 months in order to deliver a plenary lecture in order to try to give them new ideas, and that's it. Because the specialists are telling me now, no way to go beyond these intrinsic limitations of the methodology. So this is the reason why I continue, and I will continue, unfortunately, to insist on the fact that if someone is telling you, oh, you can operate under the guidance of DTI, he lies. I would like to see the results because it is not reliable. And it's definitely claimed by the expert telling we have a problem, how to go beyond. So they started to ask to neurosurgeons like me, you think that you can give us some feedback in order to change our mind in order to be more helpful in clinical practice?
Great. Thank you so much, Professor Duffau. I'm very grateful for you taking the time and answering the questions. Dr.
Thank you for your invitation.
Thank you so much. Dr.